On behalf of the Patient Safety Authority, I'd like to welcome you to this web conference titled Leadership's Role in Health Literacy and Patient Safety. My name is Megan Shetterly, and I will be your moderator for this program. So now I'd like to introduce our speaker for the webinar. Jeff Bomboy serves as a Senior Patient Safety Liaison with the Pennsylvania Patient Safety Authority for the Northeast region of Pennsylvania. Jeff has worked for the authority since 2012. He interacts with patient safety officers and various other healthcare staff in approximately 80 different healthcare facilities across northeastern Pennsylvania in an effort to decrease patient safety events. He also provides regional and site-specific educational programs in response to identified patient safety needs of Pennsylvania healthcare facilities. He has facilitated a collaboration with 11 ambulatory surgical facilities located in northeastern Pennsylvania in an effort to decrease unplanned transfers and cancellations. He co-authored an advisory column detailing that collaboration. He authored an advisory column on unsafe injection practices and drug shortages in ASF that was published in December of 2012. He is a member of the Pennsylvania Health Literacy Coalition. Previous to joining the Patient Safety Authority, he worked in various settings as a registered nurse and in administrative capacity in healthcare industry for over 40 years. So Jeff, now I'll turn the program over to you.
Thank you, Megan. We're going to look at a little different aspect today of health literacy and looking at leadership's role in health literacy and patient safety. We will, again, define health literacy, look at the scope of the problem in Pennsylvania and the United States and the implications of that. And then in today's webinar, we're going to describe leadership's role in developing a health literate organization, and then briefly look at some strategies to enhance health literacy initiatives. So in reality, only about 12% of U.S. adults are proficient in their capability to obtain, process, and understand basic health information and services needed to make appropriate health decisions. They're afraid to ask questions. They don't admit that they cannot read well. People with low health literacy are twice as likely as others to be hospitalized. They're more likely to have chronic health issues and less likely to seek treatment. Improving readability alone is insufficient to address the needs of patients with low health literacy. Forms, signage, education materials, and conversations must all be taken into account. Health literacy requires knowledge from many topic areas, including the body, healthy behaviors, and the workings of the health system. Health literacy is influenced by the language we speak, our ability to communicate clearly and listen carefully, our age, socioeconomic status, cultural background, past experiences, cognitive abilities, and mental health. Each of these factors affect how we communicate, understand, and respond to health information. For example, it can be difficult for anyone, no matter the literacy skills, to remember instructions or read a medication label when feeling sick. Numeracy is defined as the ability to reason and to apply simple numerical concepts. Basic numeracy skills consist of comprehending fundamental mathematics like addition, subtraction, multiplication, and division. These are important when dosing medications and calculating special diets, such as diabetic diets and low sodium and so forth. So education level and income does not necessarily indicate health literacy. Even highly educated, high-income individuals may not understand healthcare issues and how to maneuver through the system. We as providers take it for granted that patients know what to do and understand us, but it involves much more than the ability to read. Many skills such as speaking, listening, having adequate background information are important as well. A person can have completed the required number of years of school and still have limited health literacy. In fact, approximately 45% of high school graduates in the United States have limited health literacy skills. They may have literacy skills, but limited health literacy skills. And age becomes a major factor because as we age, we tend to decline in our health literacy abilities. This graph will show you the breakdown of literacy abilities in the United States. And as you can see, looking at the blue and the purple, you can see that approximately 36% of the adult population in this country have either below basic or basic skills. And what I mean by those, below basic skills, that's someone that can solve simple addition problems. They might be able to name what is okay to drink before a medical test. Basic health literacy skills, they can maybe do one-step math problems. They might be able to give you 2 reasons why a person with no symptoms of a specific disease should be tested for that disease. Someone with intermediate skills can figure out what time a person can take a prescription drug based on the information on the label that relates to the timing of a medication with regards to eating. And someone with proficient skills can calculate an employee's share of health insurance costs per year using a table. So that is how the breakdown of health literacy skills is. This is an international study that is done to assess skills of literacy internationally. It has taken the place of a national study that used to be done, which was last done in 2003 in the United States. And it basically doesn't give the United States very good marks as far as our abilities with literacy and numeracy skills. The average reading level for adults in the United States is an 8th grade level. Most healthcare information is written at a 10th grade level. So you can see the disparity there that is creating problems for those of us in the United States with regard to health literacy. So there are a lot of factors that influence health literacy. General literacy, of course, affects your health literacy abilities. So your general literacy, the ability to read, write, and understand written material, is a major factor in determining the level of someone's health literacy. But other factors also, such as experience with the health system, how to maneuver the health system with regards to your insurance, getting to appointments, taking medicine. Of course, the information that we provide to patients is very complex. Cultural and language factors certainly influence how they process information that we provide to them. How we communicate the information is always important. And as I said, aging certainly is a factor. And then add in all of the forms that we provide to them, telephone menus, information and instructions, and it's really a difficult process to maneuver through our healthcare system in this country. So what are the effects of poor health literacy? Well, people with inadequate health literacy skills cannot read and understand prescription labels and warnings. They maybe can't read their appointment slips. They certainly may not understand their informed consent documents. They can't understand insurance forms and other essential health-related material. Thus, they have poor self-management, inappropriate use or no use of health services, and improper use of medications. So we need to use what's called a universal precautions approach, and we're all very familiar with universal precautions for infection control and using proper techniques with gloves and masks and what have you. But we need to use universal precautions approach in health literacy because you can't tell someone's literacy level just by looking at them. A person may present themselves well, speak well, appear to understand what is going on. However, this does not mean that they truly do. So the best approach is to assume that they don't understand you until they can prove otherwise. Those that are well educated may still struggle with health-related information. We use a different language in the healthcare field that is not commonly used in everyday language. And even those with good educational backgrounds may not understand what their diagnosis means or what is being asked of them. Even someone who normally manages health information well, such as a nurse or someone in the healthcare field, may have increased difficulty under certain circumstances. When a person is feeling anxious or overwhelmed with too much information, may not be able to understand or use that health information as well as they normally would. So at the end of the day, it's best to use simple, clear language to avoid any opportunity for misunderstanding. So the three aims of the Institute of Medicine in their literature of crossing the quality chasm is safety, patient-centered care, and equitable treatment. So as far as safety, again, use of plain language and teach back, and we'll talk about these a little bit later. Use that during the medication reconciliation process so that you're sure that the patient understands their medications. Patient-centered care involving the patients in decision-making and confirm their understanding. And in equitable treatment, certainly clear communication to help eliminate health disparities and build cultural competence. So what are the costs of low health literacy? Well, when you have lower health literacy, you may not understand the importance of your healthcare needs. You don't manage your chronic health conditions appropriately or know what a health emergency is. Thus, those with low health literacy cost the healthcare system more money in readmissions, managing health conditions that have not been managed appropriately as they should have been, and ultimately, low health literacy can cost the healthcare industry approximately $73 billion a year in misdirected or misunderstood healthcare services. So it's a huge problem within the United States. And George Bernard Shaw simply said the single biggest problem in communication is the illusion that has occurred. And certainly with health literacy, that's certainly true. We are communicating with our patients, but are they really understanding what we are telling them, and can they do what they need to do once we've told them what their problem is and how they should treat it? Also, according to the AMA, they said it's neither just nor fair to expect a patient to make appropriate health decisions and safely manage his or her care without first understanding the information needed to do so. And that is what our aim is, to make sure the patients do understand. The process is very complex if you take into account the pre-visit scheduling of the appointment, the reason for the visit, then you register for your visit, you give your health history, you see the clinician, hopefully give them an accurate medication list. The clinician then gives you new prescriptions. They tell you what they think your problem is. They order tests, and so on and so forth. And this can really be called the continuum of confusion because the patients really are not understanding a lot of what is being told to them. So how can we take care of this problem? Well, we can become a health literate organization. And becoming a health literate organization is certainly not a luxury in this day and age. We need to start involving patients and families and caregivers. That's essential. They should be involved in reviewing and critiquing the material that we provide to them. They should be giving input to policies and procedures that involve them. They should be doing clinical site walkthroughs so that they can provide us with input as to how to get through the system. They should be co-presenting health literacy information to their peers and acting as liaisons for literacy programs. Again, if we don't involve the patients, we are certainly not going to really create a health literate organization. These are the 10 attributes of a health literate organization, and we'll go through each of those. They really serve as the foundation to becoming a health literate organization. And these are the 10 attributes listed. You need to have leadership that makes health literacy integral to its mission, structure, and operations. Again, leadership is the key here. You need to integrate health literacy into all of your planning, your evaluation measures, your patient safety and quality improvement. You need to prepare the workforce to be health literate themselves and to monitor progress. And very, very important to include your population served in the design, implementation, and evaluation of health information and services. You need to meet the needs of the populations with a range of health literacy skills while avoiding stigmatization. So you need to serve the populations that are in your area. Use health literacy strategies in interpersonal communications and confirm understanding. And again, we'll talk about plain language and teach back as part of this attribute. You need to provide easy access to health information services and navigation assistance. This has to do with wayfinding in your facility. Is your signage easy to understand? Do you have personnel available to get someone through your facility and get them where they need to go? Do you design and distribute print, audiovisual, and social media content that is easy to understand? Do you address health literacy in high-risk situations, including care transitions and communications about medicines? This is one area that we fall out a lot in, care transitions and making sure that patients understand what they're to do during those transitions of care. And one area that we really do not do well as an industry is communicate clearly what health plans cover and what individuals will have to pay for services. I know of one facility that is very proud that they've really fulfilled 9 of the attributes of a health literate organization, but still struggle with that last attribute with regards to what health plans cover. And it's an ever-changing field, and every year your health plan coverage changes and what you pay for services, so that's an ever-moving target. So organizations with the most successful health literacy programs have champions within the ranks of senior leadership. I can't stress that enough, that if you don't have a champion within senior leadership, you will not probably be successful in having a health literate organization. Having this kind of organizational support creates an opportunity to move health literacy practices forward and an opportunity to generate momentum to maintain health literacy efforts as a priority for the long term. This is not the flavor of the day, the flavor of the month, but it's a long-term process in becoming health literate and health literate organization and maintaining that. So leadership influence is vital. The AHRQ website, AHRQ website, has a self-assessment tool that can be used to see where you stand as far as being a health literate organization. What we need to do is change how people and organizations behave. We have to embed and spread those changes in the system. Building a health literate organization requires both incremental and systematic change. Incremental change will target future generations. We must address this across the lifespan because we retain much of what we learn as youth. It will require improved health literacies through education. One area, it really is a team effort, but nursing really can play a major role in change because they they are patient advocates. They can serve as multipliers of the overall vision and strategy, but it's not nursing alone that can do this. It is really a team that needs to work on becoming health literate. So leadership establishes the organizational culture through its language, expectations, behaviors it models, and the design of services and processes. They provide the resources for health literacy. They help communicate the needs of the population to the board, the quality committee, and departmental meetings, and again, appointing an executive sponsor or champion. So how do we make the case for health literacy? Well, we need to raise awareness. We can use some of those statistics that I looked at earlier on in this presentation. If you go on to YouTube and look for health literacy, you will find a wide variety of videos that can be used to make the point for health literacy. They're very eye-opening. Many of them are put out by the AMA Foundation, and it really shows you the lack of understanding of our patients with regards to what we tell them on a day-to-day basis and how they don't understand their diagnosis. They don't understand their medications. They just don't simply understand what we're telling them. We should build a business case, make it part of our strategic goals. We need to look at patient engagement and shared decision-making, two key words that we use these days is patient engagement, shared decision making. The patients need to be part of what we do every day in healthcare. We need to build the business case in reducing readmissions, and readmissions can be reduced greatly through the use of health literacy skills. The Wisconsin Health Literacy Coalition put out some information. They talk about one program that focused on discharge communications, and they successfully reduced readmissions by 30 to 35% by employing low-cost techniques to build an understanding of patient diagnosis, confirm medication routines, scheduling follow-up appointments, and performing follow-up calls to reinforce medication plans and answer patient questions. A Colorado initiative to enhance communication during care transitions demonstrated an average savings of over $289,000 from a $74,000 program investment. And teach-back programs have helped to reduce heart failure, length of stay, and readmissions by roughly 25%. So there is some return on investment by using some health literacy skills that can be learned by all of your staff. It also reduces errors when we are understanding our patients better and they're understanding us. Look at it from a regulatory standpoint. Health and Human Services has regulations regarding health literacy. The Joint Commission has standards talking about health literacy. And then there's a liability standpoint. Do your patients really understand their informed consent, or are we operating on patients that don't understand what we're doing to them? Some other strategies to build support, link it to other initiatives, as I said, reducing readmissions. I talked about some cost savings and return on investments. Again, looking at those statistics, get some stories from some of your patients. I'm sure patients have stories of how they didn't understand what we were telling them and how it did cause them to be readmitted or didn't allow them to take proper care of their chronic health conditions. And again, the legal, regulatory, and compliance reasons to build a health literate organization. You'll need to recruit champions. Again, you need to have a champion in your leadership team. You'll need to ask for specific actions from others. You can't just go willy-nilly and expect everyone to do something. You'll need to have people look at your educational materials. You'll need to have others help to teach the staff about teach-back. You'll need to have others look at your plain language and your documents to make sure that they're usable by your patients. Get technical assistance from health literacy experts. There are a number of experts across the country and across the state. The Healthcare Improvement Foundation, located in southeast Pennsylvania, has a collaboration with Jefferson University, and they have experts available. There are a number of states with health literacy coalitions. Pennsylvania has a health literacy coalition available with some experts. You'll need to build a support network within your own organization and with other organizations. This is not a problem within your own network. All healthcare networks have the same problem. They all need to enhance their health literacy. So work with other organizations. And most importantly, involve the patient. If you don't involve the patient, you certainly won't be as successful as you need to be. And again, it's a community-wide problem. It's not just a problem within your facility. It is a community-wide issue. So shared decision-making influences outcomes, and if we improve patient understanding of their medical conditions and treatment plan, all of the above can be realized. You'll increase patient safety, you'll decrease readmissions, you'll increase patient satisfaction, reduce health disparities. It'll be a more welcoming environment because the patients will feel that you're really interested in them and making them understand what is going on. They will better utilize their healthcare services, and they'll manage their chronic health conditions much more readily. Your HCAP scores will certainly improve. We have a facility within the Northeast region that really worked on improving the patient's understanding of their medications at discharge. Failure mode effects analysis was done, and they worked to make the patients understand their medications. They greatly improved their HCAP scores on the unit that they trialed this in, and they expected to take this to their other units. And it was double-digit improvements in their communication about medications and discharge information. So everybody's really concerned about making their HCAP scores better. Well, you can improve at least 4 of those scores by making your patients understand what the doctors are talking about, what the nurses are talking about, make them understand what their medications are for and why it's important for them to take them, and then discharge information. So I said we talk a little bit about some interventions, just a few of those interventions. One is, again, those universal precautions. Expect that your patients don't understand you until they prove that they do understand you. Use of plain language, we'll talk about that a little bit more. Teach back, brown bag medication reviews, and staff education. So what is plain language? Plain language is what I also describe as living room language. It's that language that your mom and dad, your brother and sister, how they converse at night when they're sitting on the sofa talking about their day. It's the language they use. It's common language. It doesn't include jargon that the other one doesn't understand. It certainly doesn't include medical jargon. It's information that they want and need to know. It's just plain everyday language. It's simple words, short sentences, short paragraphs, no medical jargon. Use of white space. You notice this slide doesn't have words completely across the entire slide. There's white space. There's visual aids. You want to be careful with color. Certainly cartoons, photos, pictographs, along with spoken explanations can help to increase comprehension. It's okay to highlight or circle key information using headings and bullets. Clear or simple language, clear language. Don't use words such as benign, chronic, cardiac, edema. You can see on the right-hand side of the slide better words to use that patients can understand. So that is plain language. It's not using medical jargon. Teach back is asking patients to recall and restate what they have been told, and it's considered to be one of the top 11 patient safety practices based on strength of scientific evidence. It's really allowing the patient to tell you what they thought they understood you to say. And what teachback is not a test of the patient's knowledge. It is a test of how well the concept was explained. So really it's a test of how well you've explained to the patient what you wanted them to understand. This is a schematic of the teachback method. The idea is to explain the self-management process, what you want the patient to do when they go home. Then you assess their knowledge by asking them to teach it back to you what they thought they heard you say. Then if they didn't quite get it right, you clarify to the patient what you, again, want them to do, and then they'll repeat it back to you again. And it's a cyclical thing that you continue to do that until you understand that the patient understood what you said. So you want to limit it to the 3 to 4 most important things you want the patient to do. You can't give them 10 things. They won't remember 10 things. 3 or 4 things. You want to say to them, we've gone over a lot of information. What have we discussed? How will you make it work at home? What will you tell your spouse about your condition when you go home? And have them tell you back what they thought you said. Do this with medications in particular. They've done studies, and there's a study that looked at some interesting research. The researchers asked patients how they would take the medicine and handed them a pill bottle. Almost half of them did not understand the instructions on at least one of the labels they looked at. And interestingly enough, for patients with adequate literacy, 38% missed at least one label also. So even patients with good literacy don't always understand medication labels. So it's important to do teach back with medications especially. So this graph shows the results of the study. The bottom axis is the patient literacy level, and they were categorized into low, marginal, or adequate literacy. The yellow bars show the percentage of patients in each literacy level who could read the instructions on the pill bottle correctly. The green bars show the percentage of the patients who actually took the right amount of pills out of the bottle when showing how they would take the medicine. And what was troubling to see how many patients, they read the prescription bottle correctly, but they didn't take the medicine correctly, so they really didn't understand what they were reading. Now what they've done, so if you notice in the first slide, it just said take 2 tablets by mouth twice daily. Now if they've clarified that by saying, say, take 1 tablet in the morning and 1 at 5 p.m., you can see how they, not only did they understand what they read, but they took the medication appropriately also. So it's important to make the medication labels as clear as possible. So you tell them to take a medicine twice a day. They don't know what twice a day means. They don't know if it means 1 in the morning and 1 at lunch, 1 in the morning and 1 at dinner, 1 in the morning and 1 at bedtime. You need to specify 1 in the morning and 1 at 5 p.m. if that's what you want. So again, the clearer that you can make it for the patient, the better. So again, staff education. You need to educate leadership on health literacy skills and the problem, the scope of the problem. You need to educate your employees and your clinicians. You need to educate them on plain language, teach back, a shame-free environment, that we make sure that we're not stigmatizing those with low health literacy skills and those that can't read well. We need to infuse the issue of low health literacy into the development of all of our processes. We need to develop health literacy leadership teams. Again, leadership needs to be an integral part of this. And we need to conduct a review of health literacy friendliness. Do we make our materials health literate friendly? Do we make our facilities friendly? Can people maneuver through them? Are they looking at signs that say radiology? Do they know what radiology means? Or are we saying x-ray? Are we saying ultrasound? What are we putting on our signage so that patients can understand? Do we have patient advocates that can help get patients through our system? Do we have someone that can help them understand their bills when they leave the system and they get a complex bill? Are we doing a good job at transferring patients between, when they leave our hospital and they're going to be following up with their family physician? Have we given them proper instructions so that they know when to go back to their family physician? Have we made them understand that they need to do follow-up appointments or have follow-up tests? Have we made it friendly for them? So there's lots of things we need to do to become health literate, to become a health literate organization. And it all really starts with leadership and having a leadership champion in driving this down to the staff level. The staff needs to be educated in health literate techniques, and all will be better for all of our patients and our staff. Staff will be more satisfied because they know that they're doing a better job in helping their patients to better take care of themselves. And with that, we can open it up for questions. I'll hand it back to Megan.
Thanks, Jeff. That was a very informative presentation that contained valuable information that everybody can use in their organization. So that does conclude our slide presentation portion of our program. But now we would like to begin our question and answer period. The one question that we have is, do you provide training on health literacy at facilities?
Yeah, actually, any of our patient safety liaisons are more than willing to provide. We have 1-hour program. We actually have a 4-hour program that we can provide at any facilities. The 1-hour program gives an overview of what health literacy is, what the scope of the problem is, similar to the beginning of this presentation. And it does go over those techniques that you can use. We do view some of the videos that are available to really get the staff engaged into understanding the real scope of the problem. So that can be done in your facilities at your request. we can set that up anywhere. If you just contact your PSLs, we would be more than glad to do that. We can provide continuing education credits for nurses. If you do request that, again, we have a 1-hour program that can be done for your managers, and they can provide that information then to their staff. We can do it for staff level, however you would like to do it. We can certainly do it for your leadership team. We have this presentation that we can do for leadership. And then we do have a 4-hour program that we have done regionally that is also available that goes into much, much more detail than our program today and our 1-hour program. So yes, it is available. We would be more than glad to do that anywhere in the state.
So Jeff, I was just thinking of this question, and this question popped up in our Q&A. They said it was an excellent presentation, very informative. It says, do you present this program at colleges or nursing programs?
Yes, we actually do. Meg and I have done this at some nursing programs, and we would more than love to do it at colleges and nursing programs. It's an excellent program. I have done it at another nursing program in the northern part of the state just recently. This is a good time to get those students involved in health literacy when they're first going into their nursing programs and their nursing profession, to really get them involved in that. So we would be more than happy to go to schools and nursing programs and colleges to present these programs, absolutely.
Just an addendum to that, I think somebody else asked a question, and it wasn't necessarily do you present the program, which you did answer. It's, are the med school and nursing schools taught health literacy outside of us coming in to teach it, I guess is her question.
That's a good question, and I don't know a correct answer to that because, yes, we have been invited in to provide this education. I've done it for medical residency programs. I've done it for nursing schools, but I don't know if it is part of their curriculum or not. I do not know that. Good question.
Yeah. There is a gentleman that looks like he's asking a question. How do we get in touch with you to arrange a lecture?
If you get in touch with your patient safety liaison, and if you don't know who your patient safety liaison is, you can call our office in Harrisburg at 717-346-0469, and they will get you in touch with the proper patient safety liaison, and they will arrange the program for you.
I have another question here. This is a very interesting one, and it's asking if there's any software out there in bringing educational materials up to the appropriate health literacy standards.
There are actually there are programs available for you to evaluate your educational material. If you I'm drawing a blank as to the name of those. One of them is SAM, I believe. If you do a Google search and look for health literacy, you will be brought up to a host of information. If you look on the Agency for Healthcare Research and Quality website and look under health literacy, it will bring you up to some educational materials that helps you to see if your educational materials are up to health literacy standards. The ARC website has a lot of information on, and there's where you should probably start your search for that type of thing, yes.
Okay. I have another one here. It says, have you heard of using teach-back method when discussing discharge plans with patients? I am looking for education to give to case managers on using teach-back when discussing what the discharge plan is, such as discharge with home health.
I mean, anyone can use the teach-back method. As I showed on the slides, it's really a matter of you telling the patient what you want them to do or what they need to know when they go home, and then asking them to repeat it back to you and continuing that cycle until you are sure that they understand. It's the only way you're going to truly understand that they understood. And if you're sending them home with home health, You certainly want to make sure that they understand that home health will be coming to visit them, and make sure that they understand what home health's role will be. And so you teach them, tell them what home health will be doing when they come into their home, making sure the patient understands that by them telling you back what home health will be doing. And then home health would follow up on that when they come into the home by saying, this is what we're doing when we're coming into the home. And then again, they can use the teach back method to make sure that the patient understands exactly what they're going to be doing. So this goes across the continuum of care for each, whoever is the provider, whether that be your case manager, whether that be your home health agency, whether that be your primary care physician, your rehab facility. The teach back should carry through from provider to provider. I hope that is what they were asking, is the question.
Yeah. Where would you direct them for information specifically?
Again, there's a lot of information on the Agency for Healthcare Research and Quality website. If you look for health literacy on there, there's actually a toolkit, health literacy toolkit. It has a wealth of information on it. There's PowerPoints, there's some videos. As far as teach back method itself, if you go on YouTube and look under health literacy, you'll actually find a number of videos utilizing the teach back method, so you can get a real idea of how teach back works. The videos are very valuable. They're done by the AMA Foundation, very useful.
Just along those lines, Jeff, do you suggest the practice of doing like role play or simulation with teach back before you actually put it into use?
Yeah, that's always a good idea. When you're starting to teach your staff how to use these techniques, certainly, simulation would be an appropriate thing to do just to get used to practicing that. Because teach back really should only take a few minutes of your time once you've practiced it and gotten used to using it. They say typically a provider-patient interaction will take no more, using teach back take no more than a couple of minutes extra over what you're doing now. But you've got to practice it. You've got to get used to using it. So, yeah, simulation certainly is a good way to do that.
Yeah, I know a facility that did that unit specific, and they started small and then they grew big, and they did kind of train the trainer, and they did simulation and role play, because I think, we're in healthcare so long, we don't realize the terminology. Terminology in itself is a big, long word. How many syllables is that? So, the words that we're using. Somebody asked a question about what is ARC, and she spelled it A-R-C. They may not know that.
It's actually AHRQ, Agency for Healthcare Research and Quality, AHRQ. It's ahrq.org. If you go on the website and get Agency for Healthcare Research and Quality, and that's where you'll find this health literacy toolkit.
Okay, I have another question. How do we make the case for health literacy with leadership?
Well, again, I think that's using a number of techniques, such as in the presentation, using some statistics to show the scope of the problem, certainly showing what the return on investment can be, and that's through such things as finding statistics on how you can reduce readmissions, because as we know, the government penalizes facilities for readmissions. So if you can reduce readmissions, certainly one area that you could start to focus on immediately would be heart failure readmissions, because we know that they're one of the biggest percentage of readmissions in many healthcare facilities. So if you can provide simple, precise discharge instructions to those heart failure patients. I've seen heart failure booklets that have been provided to heart failure patients with so much information that even the most health literate person on earth probably couldn't comprehend all of that information. So you need to break it down into 3 or 4 of the most important points at first and expand on that as time goes on, using every possible moment for teaching. So again, make the case, build the business case. If you provide us with the resources to give these patients the proper education using health literacy techniques such as teach back, plain language, properly done educational materials, and we can reduce these readmissions by 25% or 30%. Your return on investment for that extra staff member to do this or to make phone calls to go over their medications the day after discharge or the week after discharge and prevent those readmissions, you need to show that there's some return on investment by reducing readmissions. You need to show, if you can, that patients are managing their chronic health conditions better, again, so they aren't coming back into the hospitals frequently. Again, showing those statistics of the scope of the problem so that your senior leadership team can understand that there is a real problem in the state and in the country. That's how you're going to get leadership involved and engaged.
And Jeff, I just have another question. This person says, are there any assessment tools available for evaluation of teach-back methods?
I don't know if there's any tools per se, but you'll know that you're effective if, when you're using the teach-back method, that the patient can then recite back to you what you've told them and that they seem to understand that. And keep in mind, it may not always be the patient that is the person that will learn best. It might potentially be a caregiver. It could be a spouse, a child. It may not always be the patient, depending on the patient's conditioning and cognition. So using teach-back may not always be using teach-back with the patient, but maybe a care provider. And again, there may not be a tool to measure that, but you're going to be able to measure that by the patient or caregiver's ability to provide that proper care for their health condition or their chronic health condition, by not being readmitted to the hospital, by taking their medications appropriately, by not needing frequent follow-up care by their primary care provider because they are properly caring for themselves or the caregivers providing proper care for the patient.
And Jeff, I don't mean to overshadow what you just said, because 100%. I just did a presentation myself. ARC does have a link to a teach-back observation tool that you can use, and I just know that just because I looked it up the other day and I had found it online. So it's the Agency for Healthcare Research and Quality. They have a competence 10 list of things that you need to use and then an observation tool, and you can use those in tandem when you're doing your education and observations. But I just found that out.
Great. Yeah, there is so much information on the ARC website for health literacy. You could spend days looking for information there. There's so much information. That should be your number one first resource, not the only resource for health literacy information, but probably your first resource, and then go from there.
No other questions. And I guess I would ask a question. This fabulous presentation, and my question would be, talking about the community, the continuum of care, and that involvement with all of those entities that are caring for the patient during that continuum of care. You said you've seen some agencies that do it and do it well. Is there any references to those people, or if people wanted to network or find out how other people are doing it, is there some way they could get in touch with them?
I think if they wanted to get in touch with them, probably get a hold of your PSL, and then we could probably try to connect people if they're willing to, share what they've done. That would probably be the best way to do it. Yeah.
So thanks, Jeff. That really was very informative. Really contained a lot of valuable information, and we appreciate that. So thank you, everybody, and this concludes our webinar. Thank you.